just be aware of that. So let's kind of get started. And the first thing, and again, I will still say while some of these are a little more difficult, they're also very clinically relevant. Most of these are. So, and this is a common thing that you have to do, is that patients are prescribed or in a hospital and using an opioid analgesic. We kind of talked about those briefly, those controlled substances, the very strong morphine derivative analgesics. And sometimes they need to be switched from one opioid analgesic to a different opioid analgesic. So what we have available to us are equal analgesic dosings, all right? And that's what this table is. It's basically telling you the dose of the drug that would be equivalent to each other. So my first question would be, if you look on this table, which is more potent, oxycodone or hydrocodone, taken orally? So do be aware that this table has a parenteral, and what does parenteral mean? IV, so an IV route, and it has an oral route. So again, we have to be careful there because you can give these drugs either by injection or IV or orally. So if we say oral, how would you compare oxycodone to hydrocodone? Well, we'd look at the number here, and basically we could see that 30 milligrams of hydrocodone would be equivalent to what? 20 milligrams of oxycodone. So which one takes less drug to produce the same effect? Oxycodone. So again, the idea is here you can choose numbers off this table that shows you the relative numbers that are equally analgesic. All right, so we'll use this in our question here in a little bit, but I just wanted to explain that. So it starts off as that a patient has been taking morphine 15 milligram immediate release tablets with the instructions to take one tablet by mouth every 6 hours. Okay. So going into this, because we are eventually going to need to convert this patient to some other drug, we need to know the total daily amount so that we start by taking with the opioid that they're currently on and calculating the total daily amount of that opioid. If it is an opioid with acetaminophen, kind of like hydrocodone with acetaminophen or oxycodone with acetaminophen, we disregard the acetaminophen. We don't care about whether there's any Tylenol in the tablets or not. We are converting from one opioid to another. Now, in this specific question, it doesn't have it, but for morphine now, tell me, given the instructions for the SIG, what is the total daily dose of morphine that this patient is taking? So I'll give you just a minute to kind of work on this one. We want milligrams per day. The instructions for the patient. As you're working on this, I would warn you that given the different questions I give you, patients can take more than one tablet at a time. They might take one tablet, 2 tablets, and so forth. So make sure you look at the total number of tablets they're taking, the frequency that they're taking it, and then finally the strength of that dosage form. So 3 things: how many tablets, how often they're taking it, and the strength of those tablets. Show you my work up here, and that's what I was saying is that the patient is starting off by taking one tablet. So they're taking one tablet, and they're doing it every 6 hours. Means they're getting one dose every 6 hours, and we want to know how much they're getting per day. So there are 24 hours per day. So we can see that by doing the 24 divided by 6, we're essentially saying they're getting 4 doses per day. Each dose is 1 tablet. So essentially 4 tablets per day times 15 milligrams per tablet ends up giving us essentially the fact that we get 60 milligrams a day. 4 times 15 is 60 milligrams per day. So far, so good? Of what, though? This is where I'd still argue to make sure you finish with your units here. That is 60 milligrams per day of morphine. That's how much morphine they're getting. So now the problem is in the hospital, they're complaining of some nausea. Morphine does cause a lot of nausea, causes a lot of constipation as well. But here the nausea is the problem, so the doctor wants to go ahead and switch them to a different opioid analgesic called hydromorphone. Don't get that confused with hydrocodone. It says hydromorphone. So what is an equal analgesic dose to hydromorphone? If we went from what they're taking, the 60 milligrams per day of morphine, and we wanted to know equivalent dose of hydromorphone, what would it be? So I'm going to go back and show you the table here. And again, so if we were to go to hydromorphone, we can see that its value here, and I'll circle it a couple of times, is 7.5, equivalent to, again, these are all oral doses, 30 milligrams of morphine. So we have 7.5 milligrams of hydromorphone is equivalent to 30 milligrams of morphine. So that's the proportion that we're going to set up and use. You can do this a couple of different ways. You can set it up as a proportion if you want, or in this case, I multiplied such that my units canceled. I used the dimensional analysis. As a reminder, we have 60 milligrams per day of morphine is what the patient's on, and we set up the proportion using the table that said that 7.5 milligrams of hydromorphone is equivalent to 30 milligrams of morphine. So if I multiply it by that way, milligrams of morphine cancel, and I end up with milligrams of hydromorphone. So 60 times 7.5 divided by 30 gives me 15 milligrams per day of hydromorphone. Anyone have any questions on where those numbers came from? Can you see these numbers in the table? That number was the number for hydromorphone. This was the number for morphine. And again, we're starting with morphine. So that's why we're going to multiply it such that milligrams of morphine cancel, and we end up with milligrams of hydromorphone. All right. And again, my questions will start with that. However, the problem here is in practice, is this person has probably been on morphine for some time, and they have developed a resistance, meaning they have probably needed a larger dose over time of morphine to overcome the resistance the body has. When you switch to a totally different opioid, that resistance goes away, and so you could very likely overdose the patient by switching them to exactly equal doses because of this difference in what we call cross-tolerance. Because they've developed tolerance to morphine, does not mean they'll have that same tolerance to hydromorphone. So we need to back the dose down. My point is here, when you switch to an equal analgesic dose, we do what we do, we have to lower it just to be safe because that dose may be too high. The amount to lower it is not clinically universal. So I've seen anywhere from 20% to 50%, depending on how much tolerance the patient may have built up over time to the initial opiate. I will always provide you the percent in the formula, in the question. So again, just realize I'm saying 25% in this question, but it might be a different number in practice or it might be a different number on a different question. This percent is not fixed. But here the question says, due to this loss of, or lack of cross-tolerance, we should back the dose down and reduce it by 25% to be safe. All right? So what is the new dose? What is the new daily dose if we need to reduce it by 25%? I'll move on, but we've had questions like this before. Is the percent reduction what we need to know? Do we need to know how much we're reducing it? Well, we have to turn that around and say, okay, if I'm going to reduce it by 25%, meaning from 100, I'm going to subtract 25%, what I need to actually use is the fact that I want 75% of that dose. If I reduce by 25%, it means I still need to have 75% of that dose. So 75% of that 15 milligrams per day shows me that I would get 11.25 milligrams per day of hydromorphone. And that's the strength every day. That would be the daily dose we would need to give them. Okay. All right. Now, this was done in the hospital, but they were only on it for a day or so when now they're ready to be discharged from the hospital. They don't want the patient to continue to be on hydromorphone because it's not in an extended release form. I won't say that now, but it's not in a readily usable form. So they want to change it to an easier to use form of extended release oxycodone so they can limit the number of doses per day. So we've got to convert it again. So now what I want you to do is to convert the dose that we just calculated, the 11.25 milligrams of what? Hydromorphone oral, convert that to oral oxycodone. Okay, use that table. This time we don't have to reduce for cross-tolerance because they were only on the hydromorphone for a day or so. So I'm not worried about that. We can use the equal analgesic dose in this case. Find me that dose, but then we're going to have to convert that into essentially how many of, or what strength of the extended release oxycodone tablets would we give every 12 hours? Because we're going to have to take that total daily dose, divide it in 2, and find the right strength of the tablet to give. So start by just determining the equal analgesic dose, and I'll just back up to here so everyone's on the same page. What we're trying to find is for 11.25 milligrams of hydromorphone, what is an equivalent dose of oxycodone? Okay, so let's see. Did you get this number here for oxycodone and this number here for hydromorphone? So let me just go back and make sure, where do we get those numbers from? So again, we've already gotten the oral dose for hydromorphone is 7.5. Now we got to go down to oxycodone here, and that's where that 20 is. So now we're comparing the hydromorphone 7.5 milligrams to the oxycodone 20 milligrams. We're saying those are equal, so that's the information we're going to use. So that's where those numbers came from. This is where we're starting with, so I'm going to multiply my 11.25 times 20, and divide it by 7.5 so the milligrams of hydromorphone cancel, and I get milligrams of oxycodone. When I do that, I get 30 milligrams of oxycodone. So far, so good. Did you guys get 30, I hope? Hopefully you set that proportion up or use those numbers. Okay. Now, the only thing we're doing at that point, that's the daily dose. They give that daily dose how often, though? Every 12 hours, which is how many doses per day? 2 doses per day. So if this is 30 milligrams per day, if I divide it by 2, I need 15 milligrams now, not per day, but per what? Per dose. If I have 2 doses of 15 milligrams, since it's dosed every 12 hours, that would give me my total daily dose of 30 milligrams a day, which is equivalent to the amount of hydromorphone I needed to get. All right. Now, this question is more complicated than you would see on the test. You see where I made you do it twice. I made you go from morphine to hydromorphone and then from hydromorphone to oxycodone on a test question. And if you look at the endless practice problem, it's just a single conversion from one opioid taking at this amount where you have to calculate the amount per day. You then convert to the new opiate. You then reduce by whatever the percent you need to do for cross tolerance is. Then you convert it to the based off of the doses that you have available, how often that they actually are dosed. Figure out the number of milligrams per dose. Okay? All right, well, let's move on. Okay, I know some of you may be a little bit back, but there is an endless practice problem for that, but we got more stuff to do, all right? So that was opiate conversion, something that happens. Something that's even more frequent, and you were gonna do this a ton a year from really right about now. The P2 labs are all about calculating for renal adjustments for drug doses that are removed by the kidney. So just to kind of set this up, a lot of drugs are removed by the kidneys and are excreted into the urine. Just if it makes sense to you, if the kidneys don't work very well, what happens to the level of the drugs in the blood? They go up because they're not eliminated from the body. And if they go up too much, they can become toxic. So oftentimes we have to adjust the dose of a drug based off of the renal function, meaning if renal function goes down, what do we think we need to do with the dose? Do we need to increase that dose or decrease that dose? Decrease it, because less kidney function, less elimination, the higher the levels get, so we want to start at a lower amount. So oftentimes we need to lower drug doses proportionally depending on what their renal function is. So the first part of what we're doing here is just calculating that renal function. So for all of these questions, I will always provide you with the formula so you don't have to memorize any of the creatinine clearance formulas, whether it's this Jelliffe or the Cockcroft-Gault one on the next part. It's a matter of putting the right information into the formulas and then being able to calculate it. So in this question, we have a 64-year-old female patient who's hospitalized with acute kidney injury resulting from severe community-acquired pneumonia. So she's got a bad infection, and that's caused her kidneys to essentially fail. She was started on an IV antibiotic, cefotaxime, at 2 grams every 8 hours. She currently weighs 134 pounds, and her serum creatinine is 3.0. I'll keep using the terms creatinine clearance. Serum creatinine is something that floats around in your blood. Do you know where creatinine comes from? It's a breakdown product, and I heard it here in Lawrence, of muscle. The more muscle you have, the more baseline serum creatinine you have. The more muscle breakdown you have, if the muscles are becoming injured, the more release of the serum creatinine. The reason we measure serum creatinine is it's primarily just removed by the kidneys. So again, its levels will go up with kidney function goes down. So we can use it as a monitor or a way to kind of estimate what's happening with the kidney function. So that's why we calculate the clearance of creatinine, this breakdown product of muscle that's a normal product in all of our bodies. There's usually a normal level of it. That level will go up if the kidney's function is reduced. So we can use that. So let's measure the clearance of the creatinine. And there are a couple of different formulas that used to do that. Let's start with the Jelliffe. So I'll let you start with this. And the nice one for this one is only uses essentially age. So the advantage to that, it uses both age and serum creatinine. So I'll take the serum creatinine. That's the variable that would go down there. So would everyone get 19? What could go wrong here? It's pretty straightforward, but don't forget about this. Both formulas I'm going to show you has this adjustment factor on the end if the patient is what? Female. Why do both formulas have an adjustment for female where it lowers the value? Because females in general tend to have a lower body muscle mass. We said creatinine comes from muscle. Since most of the studies were done in men, when they derived these formulas, they made a quick adjustment for the less muscle mass in females by having this little fudge factor. Sadly for me, that may not be the case, but in general, females generally have less muscle mass than men, which is why you'll see an adjustment factor only for females, because the formula was derived first in men, then adjusted for females. Everyone get 19 milliliters per minute, and that's just the units that come across from the formula. Here's just worth knowing, and it's, well, anyways, what's normal kidney function? Greater than 60. If you get values greater than 60, usually we consider that to be a normal healthy kidney function. Less than 60 and the kidneys aren't doing so great. So really 60 to 30 is kind of stage 1 kidney disease. From 30 to 15 is stage 2, and less than 15 is really considered kidney failure. So the lower that number is, certainly lower than 60, the more impaired the kidney function is. So is this a good number or a bad number? That's kind of a bad number. So the whole point of doing this is then, remember she's on this drug here. So if she's got that bad of a kidney function, what do you think we're gonna probably need to do with that drug dose? Lower it. And again, that still depends on whether that drug's removed by the kidneys. Not all drugs are. So not all drugs are adjusted by renal function, but certain ones are, and certainly cefotaxime is. How would you know what to do? You don't calculate it, you look it up in Lexicomp. All right, or you look it up in a drug information reference, you look under the renal dosing for that drug, and in this case, this one had a cutoff of 20. Seeing if it's greater than 20, no dosage adjustment needed. If it's less than 20, we reduce the dose by 50%. So, and you can do that a couple of different ways, but the easiest way to adjust this dose, since their value was less than 20, it was 19, let's reduce it by 50% by taking this dose here of 2 grams and cutting it down in half to 1 gram. So we'll keep the same frequency, but we'll have half the dose given at the same frequency, and that would give them half the dose they would have gotten. Does that make sense why you do it? Okay, and then you have a formula, and you put the digits, and you put the numbers in the formula, and you go. So let's try this one more time. The most important formula is the next one, but to use the next formula, we do need to have the patient's weight in kilograms. Notice in the Jelliffe formula, we didn't have to factor in the weight. Now we have to factor in the weight. So quickly tell me, what is 134 pounds in kilograms? How do you convert pounds to kilograms? You got that memorized, I hope? Divide by 2.2, so we're going to take the pounds and divide it by 2.2, so we have a 61 kilogram patient. Okay. The only reason I bring that up is because now let's use this formula. And this one is called the Cockcroft-Gault formula. It is the one we'll use in lab. It's the one that most pharmacies use when calculating a creatinine clearance. So this is the most common one. And it's considered more accurate because we said creatinine comes from where? Muscle. And again, more muscle, more weight. So, well, weight is a kind of a tricky subject, but it factors in the weight. So now, again, we got to convert it to kilograms. So don't use 134 there. So use the weight in kilograms we just calculated. But you can see weight is factored in. We are still factoring in the age. And we certainly are still factoring in that serum creatinine value here. So we have 3 factors that we have to use in this formula. And then don't forget, since this patient is female, to do your little adjustment factor at the end. So I'll give you a moment to do that. Just remember to use the weight in kilograms, please. And calculate her creatinine clearance now. And again, her value, I did a bad thing here. So everyone make sure you realize here, it's 2 days later, so this is her serum creatinine, not the 3.0. It's gotten better. Her acute kidney disease has resolved. So again, as the kidneys get healthier, what happened to her serum creatinine level? It went what? Down because the kidneys can remove it now. So again, my bad for saying that, but use the 1.4 milligrams per deciliter as her current value for her serum creatinine. And let's calculate her creatinine clearance now. And since her serum creatinine has gone down, I'd expect her creatinine clearance to be a higher value than the 19 we calculated because hopefully her kidneys are doing better, which would mean a higher value for the creatinine clearance. You get 39 milliliters per minute. Okay, I show my work down below there. Including the adjustment factor for the gender. I will warn you now on the exams. I am kind of evil. Not all of my patients will be female. They will be males as well as females. But sometimes when I do, whatever values I use in here will be such that if you forget to use the adjustment factor, you'll get a different dose. Because in this case here, the adjustment is based off of 40. And what did we just calculate her value to be? 39. I guarantee if you forgot to multiply by the 0.85, you would have gotten value greater than 40, and you might have gone with this information. But in this case, since she's in this range right here, we would need to adjust her dose to the 2.25 grams IV every 6 hours, because that would be the range. So that's the wrong range. This is the correct range to use. Okay, so this last part here, this is not the difficult part to these questions. It is being able to correctly calculate the creatinine clearance so that you know which one of those ranges to use from. Okay, questions on that? We'll definitely do, anyway, so make sure you can use the formulas. We'll practice a lot more when we do this in lab. All right, now let's move on to another one, because we've done weight-based dosing based off of their body weight, their actual body weight. We have done body surface area dosing, all right? Now we're talking about there are some other drugs where we say weight-based dosing, but which weight? So the take-home message here on the question 3, you need to understand this. Actual body weight is the weight you actually weigh. ABW, actual body weight. You put yourself on a scale, that's your weight, that's your actual body weight. There are 2 other body weights that we will often use to dose drugs. The first is an ideal body weight, and you're going to see that formula here in a little bit. And then beyond ideal body weight, there's what we call an adjusted body weight. So in this question here for propofol, the issue here is it is based off of body weight unless you're obese. Because if you're obese, then a lot of that weight is fat, but the drug doesn't go into fat. But if you base it off of like the total weight or your actual body weight, you'd be getting too much drug because some of that drug's not going to go into the weight that you base that dose off of. So that's why in certain situations, depending on obesity, we want to have a more realistic weight that the drug will actually go into, okay? So first we need to do for this patient is determine whether they are obese. So the fact that we have a 41-year-old male who stands 5 feet 9 inches tall and weighs 253 pounds, let's determine if they're considered obese. And the determination of obesity is based off of what? Body mass index. So what do we have to calculate there? Body mass index. And their body mass index requires you to know their weight in kilograms and their height in meters. So let's do that. So our first step is to take their weight of 253 pounds and divide by 2.2 to get 115 kilograms. So that's their actual body weight. Actual body weight's 115 kilograms. Their height, since they are 5 feet 9 inches in height, 5 feet times 12 is 60 inches, plus 9 is 69 inches. Then using this conversion here, that 1 meter is 39.37 inches, I can convert 69 inches into my height in meters, and I have my weight in kilograms. Is everyone okay? I know you may not be able to do it at the same speed I'm going through this, but hopefully you can follow me and see these are basic conversions that we've done before, weight conversions and height conversions. And again, I always give you those factors. All right. So now using the 115 kilograms and the 1.75 meters squared, let's use the BMI formula that I will provide to you, and simply take 115 kilograms, 115 kilograms, divided by, and this is where the tricky part is on your calculator. So if you want to go ahead and do this, just try this for a second and make sure you could calculate it correctly on how you're going to input it into your calculator. Take 115 kilograms and divide it by 1.75 squared. And make sure that you can get the denominator squared, divide 115 into that, and get the same value here. And it's not mentally, conceptually difficult, but make sure you can do this on your calculator, because this would be fair game on the exam for you certainly to have to calculate the BMI. Okay? So hopefully you got a value of 38, and we would compare that back to the fact that we usually have a cutoff of 30 kilograms per meter squared as a definition of obesity. Anything with a BMI greater than 30 is considered obese. And since he is greater than 30, we're going to consider him as obese. So instead of using his actual body weight to dose, what are we going to use? His adjusted. So we need to now calculate his adjusted. The trick to adjusted is it's based off of his ideal body weight. So when you have to calculate an adjusted body weight, you have to start by calculating the ideal body weight. So here are the formulas for the ideal body weight. They're pretty straightforward, but they differ first by what? Where it could go wrong on a test? Using the wrong gender formula. So you need to use the right gender formula. So this is a male patient, so make sure that you start by using the male formula. And it just has a fixed number in kilograms that you add to it, 2.3 times each inch over 5 feet. Okay. Well, since he was 5 feet 9 inches in height, we take the 9 inches times the 2.3, add that to the 50 kilograms. So 2.3 times 9 plus 50 gives us an ideal body weight of 70.7. Okay? Not a difficult formula to use, but choose the right gender and make sure you get the inches. Now, what if they were 6'1"? How many inches over 5 is that? 13, 12, plus the 1, you just keep adding whatever the height is over than that, okay? If they're less than 5 feet, then you don't add anything to it. So you just go with that weight there. And that won't happen there. There's a different situation for that. So we'll just skip that idea. But there we have it. All right, now, finally, the adjusted body weight formula. We have everything we need to know. Let me ask you, do you know their actual body weight in kilograms? Do we know their ideal body weight in kilograms now that we have calculated it? So that's the two things we need to know. So as you go ahead and do this work, understand what you're doing is you're finding the difference between this. And if you want to be depressed, you could always calculate your own. But you can take your actual body weight, subtract your ideal. And for many of us, there is a difference there. But what we're going to do is we're going to take 40% of that difference. So take the difference, multiply by 0.4, right, which is 40%. So 40% of the difference. And we add that difference to the what, though? Don't mess this up. We add it to the ideal body weight. In this case, we said the ideal body weight may be way too low, so we're going to go 40% of the difference between the ideal and the actual. So start with ideal, add to it 40% of this difference. All right, so in this case, it was 115 actual weight minus his ideal of 70.7 times 0.4. So that difference times the 0.4 then gets added to the ideal, and he gets a total adjusted body weight of 88 kilograms. So far, so good? That was all the work. The dose itself is a piece of cake because the dose is 2.5 milligrams per kilogram once we know the right weight to use. But do you see where if we had used his actual body weight, what would the weight have been? 115 kilograms. So this number would have been much higher and could have led to an overdose of that drug. So again, not all drugs, but there are definitely some drugs that the dose is not based off of the patient's actual body weight. It could be ideal body weight in a lot of situations. We've now seen one done on adjusted body weight, and you've practiced on the chemo drugs that are on body surface area. So there are multiple types of dosing that, or weights that dosing can be based off of. So in this case, the final amount to give this patient is 220 milligrams. All right, that's the end of the dosing start. And I would still say there are 3 endless practice problems that really do, the obesity one's done well. We have a really good one for the renal dosing. And so all of those, there's a lot of good endless practice problems to keep practicing those. So take a deep breath and now picture Dr. Wu. We're getting a little scientific here, right? We're kind of, and to be honest with you, I'm doing some of these questions. She told me to because she wanted you to keep practicing on the Henderson-Hasselbalch and practicing on some of the things. I think you've had some math review in her class already. So hopefully this is not completely new. So question number 4 represents your capacity to do the basic Henderson-Hasselbalch formula. So it starts with, what is the pKa? Could you determine the pKa of a substance? All right. So in this question, we have a buffer that's made from 50 mils of a 1 molar benzoic acid, and I always will clarify what's the acid and what's the base, so that part is easy to set up in your questions. All right. So benzoic acid is an acid, and it has a Ka of the 6.3 times 10 to the negative 5th, and we're mixing that with 50 mils of 1 molar sodium benzoate, which is the salt part, or the base part in this case. Okay. So to use the Henderson-Hasselbalch formula, we got to start with the pKa of the acid. I didn't give that to you. I gave you the Ka. So could you determine the pKa? Knowing that the formula is the negative log base 10 of the Ka. So I'll give you a quick second here. Can you take 6.3 times 10 to the negative 5th in your calculator and do a negative log base 10 of that value and get the right answer for the pKa? Did you get 4.2. There's a calculator check and just being able to kind of do that part. All right. Now that's not a huge part of the questions here. Normally you are either given a pKa or have to use the pKa, and that's what we're going to do. Now that we know the actual pKa value, we can use our Henderson-Hasselbalch formula that says the pH of a system is going to be the pKa of the acid plus the log base 10 of the concentration of the base divided by the concentration of the acid. All right, so in this formula now, or in this question, what is the pH of this solution? Knowing that we just calculated a pKa of 4.2, so we have that value now, and we give concentrations here of both the acid and concentrations of the base. Okay. Always make sure, though, that you have the concentrations expressed in the same units. For me, make sure they're in molar. You'll see here in a minute here, I tend to have you make sure you're always in molar. So what does capital N stand for, just so we're all on the same page? Moles per what? Moles per liter. That's a good, you guys know that, moles per liter. You'll see that in the next part. We'll have to factor that in. But in this case, I gave you both of the concentration in molar, or moles per liter. So this is a fairly straightforward numeric one, but let's see if you can set it up right. So did you put 4.2 plus? The concentration here of the, we said of the, both of them is 1 molar. So 1 molar of the base on top of 1 molar of the acid. All right. So doing that math, what is 1 divided by 1? 1. What is the log base 10 of 1? 0. So essentially the pH is equal to the pKa, which is 4.2. It's easy breezy. I don't know why you guys struggle with this, not now, but all right, so let's make this a little more difficult. Now to this buffer solution, let's add some base. So the base that I'm adding has 0.2 moles. So we don't have to worry about changing the volume at all, but we are adding 0.2 moles of sodium hydroxide to the existing solution. And what is the volume of the existing solution? 100 milliliters. So I'm arguing I'm adding 0.02 moles of sodium hydroxide per what? 100 milliliters. My first suggestion to you is let's calculate that into a concentration molar, a molar concentration, so that we can use this formula. And the other part of this formula is when you add a base, and I'll always be clear, and hopefully that's pretty clear, sodium hydroxide, is that an acid or a base? Okay, this is where a little bit of chemistry, you got to know this. I'm not teaching this all again. So that's a base. So when you add a base, don't do that, Larry. When you add a base, you add the concentration of the base to the base, but what do you do with the acid concentration? You subtract the concentration of the base. And again, I will give you these formulas on my test. I'm not testing you on your chemistry knowledge in that sense, but can you do the math on this? All right? So let's kind of set that up. The whole trick to this one was our 0.2 moles was in 100 milliliters, right? So let's express that per liter or per 1,000 milliliters. So 0.02 over 100 is equal to X over 1,000. That basically converts it to 0.2 moles. And since that's 0.2 moles per 1,000 mils, that's 0.2 molar. So all I'm arguing here is that this amount of sodium hydroxide is equivalent to that concentration of sodium hydroxide. Now, since I know I'm starting with both 1 molar of my base and 1 molar of my acid, I can do my math here and take my base and add that together, but I'm going to subtract that from my acid. So the 1 plus the 0.2 together gets 1.2 on top. 1 minus 0.2 gives me 0.8 on the bottom. So can everyone see where the new acid and the new base come from? Once we've determined the concentration to be 0.2 molar, the one top goes up and the bottom goes down. Now, it's not equal to 0. So what is 1.2 divided by 0.8? That's 1.5. So now you just have to take the log base 10 of 1.5, which gives us the 0.176. So it's not 0 anymore. That gets added to the Ka, so we get a total pH of 4.376. And does it kind of make sense that if we add sodium hydroxide, even though it's a buffer solution, that the pH goes up at least slightly, gets higher? Yes. So what will happen when we do the same question, but we now make it acid? So in this case, it's the same amount, 0.02 moles, 0.02 moles of, in this case, an acid to the same system. So when we add hydrochloric acid here, you realize we get the same concentration, but now the numerator is subtracted while the denominator is added. So we reverse those values, so we have 0.8 moles of base over 1.2 moles of molar of the acid. When we divide 0.8 by 1.2, now the value inside the log is 0.667. Take the log base 10 of that, we get, oh my God, can you get a negative number out of a log? Base 10? Absolutely. All right. So now it's a negative number plus 4.2. When we add those together, we get a lower number at 4.024. And once again, does it make sense when we add an acid to the buffer system that the pH resulting ends up being lower than what we started with the 4.2? Okay. So, understanding that. Okay. Now, for me, I won't guarantee, but more likely to see, I try to put some clinical relevancy to that. Dr. Wu wanted me to cover that and have you practice that. But here's the deal. This is an actual formula that we can use to determine the pH of blood. All right. So again, would you agree that patients can become acidotic or alkalosis from a couple of different reasons? It could be metabolic, it could be respiratory induced. And why does the respiratory play a big role in this? Because the partial pressure of the carbon dioxide in your blood is part of what makes up the carbonic acid levels in your blood. Okay, so again, you can read the derivation. I'm not worried about the derivation. For me, as a math professor, I want to make sure you can solve that formula for any of those variables. Can you determine the pH if I give you the concentration of sodium bicarbonate in your blood? Bicarbonate's an important buffer chemical in your blood. And if I give you the partial pressure of the carbon dioxide. So the three variables, pH, bicarbonate, partial pressure of carbon dioxide. Can you solve for any one of those given the other two using this formula? And it shows you there is a relationship. The pH in your blood is what it is for a reason. It's a mixture of how much bicarbonate you have and how much dissolved carbon dioxide you have. So that's really what these questions are here. So I'll give you a moment to do this one, and then I'll work through the rest of these. So this one's the more straightforward too, because it says, what is the pH? So you really are just solving for the pH. If I tell you that the bicarbonate level is 20 milliequivalents per liter, and that the partial pressure of the carbon dioxide in your blood is 42 millimeters per mercury. And these are the correct units. I wouldn't mess with you on units on the exam. I'll give you the appropriate units to use this formula. But let's see if you can solve for it. All right, well, let's see, what did I do? So when I did this and set up and put the bicarbonate concentration, I got 20 in the numerator over 0.03 times 42 in the denominator here. So just factoring that part in, that's really 1.26. So I took 20 and divided it by 1.26 and got this value of 15.873. I then did the log base 10 of that value in my calculator, and I got 1.2. And all I had to do was add that to the 6.1 pKa to start with, and that's how I ended up with a pH of 7.3. Are you all able to do this part of the math here on your calculator? I know I'm not trying to harp on that, but that's the challenging part of some of these formulas. All right, and we got 7.3. Now, that would be the easy version. This is kind of a harder version of that same question. I'll just show my work for the sake of time, but it says, what is thy bicarbonate concentration? So do you realize you can solve for something else if you know the other two? Now I want to solve for this. So this is X right here. I don't know what that is, but what is it in a patient with a pH of 7.5 and a concentration of carbon dioxide in the blood of 39? So again, I've got the 39 that can go in here. I've got the 7.5 that can go in here. So now this is what I'm solving for. And again, I could also solve for the opposite one. I'm just going to do one version of this. But do you see where this becomes a little more complicated algebra problem here a little bit? So let's just set it up. In one sense, by putting in my numbers, I get 7.5 starting here. 7.5 is equal to 6.1 plus the log of X over 0.03 times 39. So the next thing I did here is I got rid of my 6.1 by moving it over. So do you see that 7.5 minus 6.1 gave me 1.4. So I did that. I also, and that's all I did at that step, then I fixed these values here. My next step was to convert, no, didn't do that, sorry. This is all within the log. So again, the last thing I'll still say, you got to know this. How do you get rid of a log base 10? What is the inverse function? How do you cancel the log of something? You raise it to a factor of 10 to the x. So in this case, I did 10 raised to the 1.4. 10 raised to the log of something will cancel that log. So what is 10 raised to 1.4? And that's where that value of 25.159 come in. By canceling the log, it just gets rid of all of that, but it leaves me everything in the middle. So I didn't change anything with what was in the log, it just cancels the log. Okay? I know I didn't say that great to begin with, but is everyone kind of clear on how to go from here? And, well, for the sake of time, go from this step to this step is by raising both sides to 10 to the x, and that cancels the log base 10. Then I can take these values and multiply them and get 1.17. If I cross multiply 1.17 times 25.119, that's where I get my final value of 29. Okay? Was this one a little bit harder than the pH one? Arguably, yes, that's a little bit more difficult to solve. So, but you need to be able to do that. So, and again, there is a endless practice problem that makes you solve for all three things, both pH, bicarbonate, and the carbon dioxide levels. So practice that one. That'll show you how to do this algebra so that you're comfortable in doing that. Making sure that you can cancel out a log as you're solving through that, okay? Let's move on to the last one, which is drug ionization. Would you agree? Well, the take-home message here is a drug generally has to be unionized to be absorbed. If it's an ion, if it's charged, it doesn't get absorbed from the GI tract very well. So if it's unionized, it's absorbed well. If it's unionized, it's not absorbed well. And again, would you agree our stomach goes from a low pH of 2 in the stomach to a higher pH in the intestine of usually closer to 8, okay? Acid drugs are going to dissociate in a different pH than basic drugs are going to do. So that's part of what we're trying to measure here is what is the percent ionization of either an acid drug or a base drug. And this formula is just a little bit of a tricky formula to use. Again, it practices your computation skills with your calculator. The only difference in the formula is what? If it's an acid drug, and I will always tell you whether the drug is an acid or a base, you don't have to know that. But if it's an acid drug, you're going to use the the pKa minus the pH versus a basic drug where you use pH minus pKa. So these are the only differences in the two formulas. So go ahead and let's just see, because this is a quick one, and I'll work my things. If I tell you lidocaine is a weak base, use this formula right here and calculate for me how much of that would be ionized. This is how much is ionized in this pH. In this case, we're talking about blood. So 7.4 pH. When your lidocaine gets into your blood, how much of it will be in the ionized form, meaning it will have separated into both a positive and negative charge version of it. So use that formula. Showing my work here, in this case, it's 100 divided by 1 plus 10 raised to the, again, putting the pH value first since it's a base, and then the pKa value second. Let's just start by subtracting those, and I got negative 0.5. So this is really 10 raised to the negative 0.5. So I would still say this is the biggest challenge for you guys on your calculators to be able to correctly compute that and basically be able to say, okay, well, that's equal to 0.316. So the denominator is actually 1 plus that, so 1.316 in the denominator, 100 in the numerator. Divide that out, and you get 76, and that represents 76%. Okay? All right, so the last thing I'll just show you, the same work here for an acidic drug. The only difference between an acidic drug here is now we've got to take the pKa minus the pH. So the pKa is 3.5, you'll notice that. But here we have in the stomach where the pH is 2, and here we have in the intestine where it's 8. So you'll notice when we subtract those, we get very different numbers in there. Therefore, the denominators are very different. So when you raise something to a positive or a larger number, you get a bigger number. When you raise it to a negative number, you get a very small number, okay? When you get a small number in the denominator here, you can see that's essentially 100% ionized, meaning it almost all comes apart in the stomach or in the intestine where the pH is low, whereas very little of it ionizes in the stomach because it's an acidic environment. Acids don't break off in acid environments. Acids dissociate in base environments. Bases don't dissociate in base environments. They dissociate in acid environments. So you'll kind of see that.